Imagine looking in the mirror and seeing your skin, or, even the whites of your eyes, turn this really unmistakable shade of yellow. It's quite a striking visual, isn't it?
Oh, absolutely. It's a clear signal from your body. Something's up.
But what exactly is it signaling? What's going on there?
Well, that yellowing is a really powerful signal. It's called Icterus, or most people know it as jaundice.
Right, jaundice.
Yeah. And it's basically a symptom that pops up when there's an overload of bilirubin in the body.
Bilirubin, okay.
Right. Bilirubin is this natural yellow or greenish pigment. And when it builds up too much, it leads to that characteristic color we see.
So our deep dive today is all about unpacking this really fascinating, sometimes, frankly, alarming phenomenon. We're going to explore why it happens, how doctors figure out the exact cause, and, what can actually be done about it. We're drawing on some pretty comprehensive medical sources here.
It's a great topic because it really opens up how these body processes work, or sometimes how they go slightly awry.
Right, it's like a window into our internal workings.
Yeah.
A single symptom telling a whole story.
Exactly. And to really get Icterus, we first need to talk about bilirubin itself. It's not, some foreign thing. It's actually a totally normal byproduct.
A byproduct of what exactly?
Of how your body recycles old red blood cells. Our bodies are constantly breaking down old cells, building new ones. Bilirubin is just part of that cleanup and recycling crew, a healthy process normally.
Okay, so this yellow pigment, bilirubin.
Yeah.
Where does it actually come from in a healthy person? How does the body usually handle it day to day?
Great question. Think of it like this. Red blood cells, they have a lifespan, right? When they get old or damaged, they get broken down. Mostly in the spleen and liver.
Okay.
Inside those cells is hemoglobin. That gets broken down into heme. Then the heme gets converted into something called bilirubin, which is actually green, believe it or not.
Green. Okay.
Yeah. And then that bilirubin is changed into what we call unconjugated bilirubin. That's the first form.
Unconjugated. So that's step one, the raw material.
Pretty much. And this unconjugated type, it's not water soluble. It can't just dissolve in your blood and float away easily.
Oh, okay. So it needs help getting around.
Exactly. It needs a ride. It binds to a protein called albumin. Think of albumin as its taxi through the bloodstream, taking it to the liver.
And the liver is the main processing center for this stuff.
That's right. Once it gets to the liver, specialized liver cells, hepatocytes, they take over. They use this really critical enzyme, UGT1A1.
UGT1A1, got it.
And this enzyme essentially tags the unconjugated bilirubin with something called glucuronic acid. This whole tagging process is called conjugation.
That changes it.
It does. It transforms it into conjugated bilirubin. And the key difference, this form is water-soluble.
Ah, so that's the trick to getting it out of the body.
Precisely. Now that it's water-soluble, the liver can secrete it into the bile ducts. From there, it flows into the small intestine as part of bile.
And then what happens in the intestine?
Well, mostly bacteria in your gut get to work on it. They metabolize it into urobilinogen. Some of that gets reabsorbed and ends up in urine, giving urine its yellow color.
Okay.
And the rest, the majority, becomes stercobilin. That's what gives feces their typical brown color.
Wow. Okay. That's a pretty complex but normally smooth-running system.
It really is. Beautifully orchestrated, usually.
But when we see icterus, that yellowing, it means there's a problem, an imbalance somewhere in that pathway, leading to too much bilirubin, right? Hyperbilirubinemia.
Exactly. Too much bilirubin building up. And where the process breaks down helps us classify Icterus into three main types, based on the location of the problem, really.
Okay, let's break those down. Let's start maybe before the liver. What's prehepatic icterus, sometimes called hemolytic icterus?
Right. So prehepatic means the issue arises before the bilirubin even gets to the liver for processing.
So the liver itself might be fine.
Initially, yes. The problem is that there's just way too much red blood cell breakdown happening. That's hemolysis. The liver's conjugation machinery, that UGT1A1 enzyme system, it just gets overwhelmed. It can't keep up.
So it's like a factory getting too many raw materials dumped at its door.
That's a great analogy. And because the liver can't conjugate it fast enough, the bilirubin that builds up is mostly the unconjugated type. That's the key signature here. Unconjugated hyperbilirubinemia.
Makes sense. So what kind of things cause that much red blood cell breakdown? What are the common culprits?
Well, the big category is hemolytic anemias. These are conditions where red blood cells just get destroyed too quickly, prematurely.
Like what? Any examples?
Sure. Things like sickle cell anemia, where the cells are the wrong shape and fragile, or spherocytosis, where they're too round and break easily. Thalassemia is another one.
Okay.
Also, autoimmune hemolytic anemia, that's where your own immune system attacks your red cells. Interestingly, that one's often treated with corticosteroids. And even something acute, like a bad reaction to a blood transfusion, can cause massive hemolysis and prehepatic icterus.
So it's not always a long-term chronic thing.
Not at all. The sources point out some surprising causes too, like a really large bruise, a hematoma, or significant internal bleeding.
Really? Just in a bruise?
If it's big enough, yeah. All that pooled blood breaks down, releasing hemema, overwhelming the system. And we see similar things in animals, too.
For sure?
For sure. In horses, for example, eating things like toxic red maple leaves or wild onions can cause oxidative damage to red cells, leading to hemolysis. Even snake bites or bee stings, the venom can sometimes do it.
Wow. Nature's full of surprises.
Yeah.
Are there genetic factors here, too? Things people are born with?
Yes, definitely. And they're quite interesting. There's Gilbert's syndrome. It's actually pretty common and usually totally benign.
Gilbert.
With Gilbert's, that key enzyme, UGT1A1, just has slightly reduced activity. Not absent, just a bit slower.
So what does that mean for the person?
It leads to mild, kind of intermittent, unconjugated hyperbilirubinemia. It might flare up a bit if someone's stressed or fasting or sick, but it's generally not harmful.
So a bit of yellowing sometimes, but not a major health issue.
Exactly. It shows that not all yellowing is a 5-alarm fire. Then you have much rarer, more severe genetic conditions affecting that same enzyme, like Crigler-Najjar syndrome. Type I is very serious, can even be fatal without aggressive treatment like liver transplant, because the enzyme is essentially non-functional.
Okay, big difference there. So that covers issues before the liver.
Yeah.
What happens to the liver itself is the problem. That leads us to the second type, right? Hepatic icterus.
Precisely. Hepatic or hepatocellular icterus. Here, the problem lies within the liver cells, the hepatocytes. Something is impairing their ability to do their jobs. Taking up bilirubin from the blood, conjugating it, or secreting the conjugated bilirubin into the bile.
So the factory workers, the liver cells, are struggling.
Right. And because different problems can affect different steps within the liver cell, the bilirubin pattern can be more varied here. You might see mostly unconjugated bilirubin buildup if uptake or conjugation is the main issue. Or you might see mostly conjugated bilirubin if secretion into bile is the problem. Or, quite often, it's a mixed picture with both types elevated.
Okay, so it depends on exactly what's wrong inside the liver. What kinds of things damage liver cells like that?
Oh, there's a whole range. Infections are a major one. Viral hepatitis A, B, C, D, they all target the liver, causing inflammation and damage.
Hepatitis, right?
Then there's autoimmune hepatitis, again, the immune system attacking the liver. And we see specific things in animals, too, like Thieler's disease virus in horses, or bacterial infections causing cholangiohepatitis, which is inflammation of both bile ducts and liver tissue.
And I guess lifestyle choices or things we ingest can play a big role too.
Absolutely. Alcoholic liver disease is a huge one. Years of heavy drinking can lead to alcoholic hepatitis or eventually cirrhosis, which is severe scarring.
Cirrhosis. That sounds serious.
It is. It's irreversible scarring that really messes up all liver functions. Then there's drug-induced liver injury. You'd be surprised how many common medications can potentially harm the liver in susceptible people. Acetaminophen paracetamol, if taken in overdose, is a classic example.
Wow. Even over-the-counter stuff.
Yep. Certain antibiotics, even some anti-seizure meds can do it. And specific toxins, too, like arsenic or aflatoxins found in moldy grains, or certain animal drugs like monensin.
What about chronic conditions that aren't necessarily caused by infection or toxins?
Well, cirrhosis, as we mentioned, is often the end stage of many chronic liver diseases. But increasingly common now is non-alcoholic fatty liver disease, NAFLD, and its more serious form, NASH.
Fatty liver disease. Yeah, I hear a lot about that.
It's often linked to obesity, type 2 diabetes, metabolic syndrome. Basically, fat builds up in the liver and causes inflammation and damage over time.
Okay. Any other less common causes?
Sure, there are genetic conditions like Wilson's disease where copper builds up in the body, including the liver, or hemochromatosis, which is iron overload. And even things outside the liver, like severe systemic infections, sepsis, can sometimes impair liver function enough to cause hepatic icterus. Shows how connected everything is.
Definitely. Okay, so we've done before the liver, prehepatic, and inside the liver, hepatic. What's the third category? after the liver.
Exactly. Post-hepatic icterus. This is also called cholestatic or obstructive icterus.
Obstructive. Okay. Sounds like a blockage.
That's precisely it. This happens after the liver has done its job of conjugating the bilirubin. The problem is a blockage in the bile ducts the plumbing system that drains bile, containing that conjugated bilirubin, from the liver into the small intestine.
So the drain is clogged.
Perfect analogy. And because the conjugated bilirubin can't get out into the intestine, it backs up. It spills back into the bloodstream.
So the bilirubin signature here would be
Predominantly conjugated hyperbilirubinemia, high levels of the water-soluble form. And another key clue often seen here is bilirubinuria.
bilirubinuria, meaning
Bilirubin in the urine. Because that conjugated bilirubin is water-soluble, when it backs up into the blood, the kidneys can filter some of it out into the urine, making it look very dark, sometimes like tea or cola.
Ah, I see. Dark urine and often pale stools. Right. Because the bilirubin isn't reaching the gut to color the stool brown.
Exactly. Those are classic signs of obstructive jaundice.
So what are the most common things causing these blockages? What's clogging the pipes?
In humans, the number one culprit is usually gallstones, specifically a gallstone that has moved out of the gallbladder and gotten stuck in the main pipe, the common bile duct. That condition is called choledocholithesis.
Gallstones in the main duct. Okay.
They can act like a plug, completely blocking bile flow.
But it's not always stones, I imagine.
No, definitely not. Tumors are another major cause of obstruction. Pancreatic cancer, especially if the tumor is in the head of the pancreas, which sits right next to the common bile duct, can squeeze the duct shut.
That sounds very serious.
It often is. Also, tumors of the bile ducts themselves, cholangiocarcinoma, or biliary strictures, which are narrowings of the duct, maybe from scarring after surgery or chronic inflammation.
Inflammation can cause blockage, too.
Yes. Cholangitis is inflammation of the bile ducts, often due to infection behind a partial blockage. Then there are autoimmune conditions like primary biliary cholangitis, PBC, where the immune system slowly destroys the small bile ducts within the liver.
PBC, right?
And primary sclerosing cholangitis, PSC, which causes chronic inflammation and scarring of the larger bile ducts, leading to narrowing and blockages, often associated with inflammatory bowel disease, actually.
Interesting connection. Are there any other, maybe rarer causes?
Well, there's biliary atresia, which is a serious condition in newborns where the bile ducts didn't form properly or are completely blocked, needs urgent surgery.
Wow, in infants.
Yeah. And going back to our animal friends, in horses, sometimes a severe displacement of the large colon can physically pinch off the bile duct. Shows how anatomy can play a role.
Okay, incredible range of causes across these three types. So we've covered the why. Now let's shift to the how. How do doctors actually figure out which of these is causing the yellowing? It sounds like detective work.
It really is. It starts with a clinical assessment. The first clue, obviously, is seeing the yellowing the icterus. It's often most noticeable first in the whites of the eyes, the sclera. That's called scleral icterus.
Why the eyes first?
The sclera just seems to have a high affinity for bilirubin, so the yellow shows up there even when blood levels aren't super high yet. It's often the most reliable early sign.
Okay, so observation first, then what?
Then comes taking a thorough patient history. This is absolutely crucial. The doctor needs to ask, when did the yellowing start? Did it come on suddenly or gradually? Are there other symptoms?
Like what kind of symptoms?
Intense itching pruritus is a big one, often points towards cholestasis, that bile flow blockage. Dark urine, pale stools, we talked about those. Abdominal pain, especially in the upper right side. Fever, unexplained weight loss, nausea, vomiting.
All potential clues.
Exactly. And then broader questions. What medications are you taking, including over-the-counter stuff and supplements? How much alcohol do you drink? Any recent travel? History of blood transfusions? Any family history of liver disease or jaundice? All these details help build the picture.
And in the hands-on part, the physical exam, what are they looking for there?
Well, besides confirming the jaundice, they're looking for other signs that might point towards the cause. Are there signs of chronic liver disease, like spider angiomas, little spiderweb like blood vessels on the skin?
Okay.
Or palmar erythema, unusual redness of the palms? Is the liver itself enlarged, or the spleen? That can happen in various liver conditions. Is there tenderness when they press on the abdomen, particularly the upper right quadrant where the liver and gallbladder are? And they'll also assess mental status. Confusion or neurological changes can be a sign of severe liver failure, hepatic encephalopathy.
Okay, so history and physical give you strong suspicions. Then you need confirmation. presumably with tests.
Absolutely. Blood tests are really the cornerstone of the diagnostic workup.
Which ones are most important?
First and foremost is bilirubin fractionation,
Yeah.
measuring the total bilirubin level and then critically breaking it down into the direct, conjugated, and indirect, unconjugated types.
Because that ratio tells you a lot, like we discussed.
Exactly. Predominantly unconjugated points towards prehepatic causes like hemolysis or maybe Gilbert's or other issues with hepatic uptake conjugation. Predominantly conjugated strongly suggests a problem with excretion from the liver or a posthepatic obstruction. That distinction is huge.
Okay, bilirubin levels sorted. What else in the blood?
Next up are the liver function tests, or LFTs, though technically some measure injury more than function. The key ones are AST and ALT. These are enzymes inside liver cells.
AST and ALT.
If AST and ALT are really high, it generally signals hepatocellular injury damage to the liver cells themselves. Think hepatitis, drug injury, etc.
Okay. What about tests for obstruction?
For that, we look mainly at ALP, alkaline phosphatase, and GGT, gamma-glutamyl transferase. These enzymes are associated more with the bile ducts.
ALP and GGT?
If ALP and GGT are markedly elevated, much more so than AST and ALT, it strongly suggests cholestasis that impaired bile flow, likely due to obstruction. So the pattern of LFT elevation is very informative.
Right, comparing the different enzyme levels. Smart.
Then there are tests that do measure the liver's actual synthetic function, its ability to make stuff. Albumin levels, for instance. Albumin is a protein made by the liver.
So low albumin might mean?
Could mean chronic liver disease. The liver isn't making enough protein. Same with prothrombin time, or PTINR. That measures blood clotting.
Clotting factors. Also made by the liver.
Many of them are, yes. So if the PTINR is prolonged, meaning blood takes longer to clot, it can indicate impaired liver synthetic function, often seen in significant liver disease or cirrhosis.
Got it. What about a regular blood count, like a CBC?
Oh, yes. The complete blood count, CBC, is very important, too. It checks for anemia. If it's prehepatic icterus due to hemolysis, you'd expect to see anemia, possibly severe.
And signs of the body trying to make new red cells.
Exactly. You'd look at the reticulocyte count. Those are young red blood cells. A high reticulocyte count indicates the bone marrow is churning out new cells to compensate for the ones being destroyed, typical of hemolysis.
Okay.
The CBC also allows a look at the red blood cell morphology under a microscope. Are there abnormally shaped cells like spherocytes? Are there Heinz bodies, suggesting oxidative damage? Direct clues for hemolysis.
So many clues in the blood. Are there even more specific tests sometimes?
Oh, absolutely. Depending on the suspected cause, doctors might order viral hepatitis serology, tests for Hep A, B, C antibodies antigens, autoimmune markers like ANA, ASMA if autoimmune hepatitis is suspected, or genetic tests like for Gilbert's or hemochromatosis.
Makes sense. What if pancreatitis is suspected as the cause of obstruction?
Then they'd check amylase and lipase levels, enzymes that are typically elevated in pancreatitis.
Okay, so blood tests narrow it down significantly. What about actually seeing what's going on inside? Imaging.
Right. Imaging studies are the next crucial step, especially if obstruction is suspected or the cause isn't clear from blood tests.
What's usually the first imaging test?
Often it's an abdominal ultrasound. It's non-invasive, uses sound waves, no radiation, readily available.
And what can ultrasound show?
It's excellent for looking at the gallbladder for gallstones. Crucially, it can see if the bile ducts are dilated or widened. Dilated ducts are a strong sign of a blockage downstream.
Ah, like a backed up pipe bulging.
Exactly. Ultrasound can also sometimes spot masses in the liver or pancreas or fluid collections like abscesses, and it can be used to guide procedures like biopsies if needed.
Okay, what if the ultrasound isn't definitive or they need more detail?
Then a CT scan might be next. Computed tomography, it gives more detailed cross-sectional images.
Better for
Often better for identifying masses, especially in the pancreas, or characterizing liver lesions. It can also be better at detecting subtle bile duct structures sometimes. Usually involves IV contrast dye.
Right. Is there anything specifically good for just looking at the bile ducts?
Yes, there's MRCP, magnetic resonance cholangiopancreatography.
That's a mouthful.
It is, but it's basically a special type of MRI scan that's optimized to create really detailed pictures of the bile ducts and the pancreatic duct.
Like a roadmap of the plumbing.
Precisely. And the big advantage is it's non-invasive, no contrast dye usually needed, no radiation. Great for diagnosing stones, strictures, duct abnormalities.
Okay, so ultrasound, CT, MRCP. Those are all ways to look from the outside. Is there a way to look directly inside the ducts?
There is, but it's more invasive. It's called ERCP, endoscopic retrograde cholangiopancreatography.
Endoscopic, so using a scope.
Exactly. A flexible scope is passed down the patient's throat, through the stomach, into the first part of the small intestine where the bile duct opens. They can inject dye directly into the ducts and take x-rays. That's the retrograde cholangiopancreatography part.
But you get direct visualization.
You do, but the really powerful thing about ERCP is that it's not just diagnostic, it can be therapeutic at the same time.
Meaning they can fix things during the procedure.
Yes. If they see a gallstone stuck in the common bile duct, they can often remove it right then and there with special tools passed through the scope. If there's a narrowing or stricture, they can place a small tube called a stent to hold the duct open.
Wow, diagnose and treat in one go.
It's incredibly useful, especially for post-hepatic obstructive jaundice caused by stones or strictures. It's often the first-line treatment in those cases.
Okay, and what if, after all that, the cause of liver problems is still unclear?
That's when a liver biopsy might be considered.
Taking a small sample of liver tissue.
Exactly. Usually done with a needle through the skin under local anesthetic, often guided by ultrasound or CT. The tissue sample is then examined under a microscope by a pathologist.
What can that tell you?
It can diagnose specific liver diseases that might not be clear from blood tests or imaging, things like autoimmune hepatitis, certain storage diseases, or NAFLD-NASH. It can also assess the severity of liver damage, how much inflammation or scarring, fibrosis, cirrhosis there is. That information is vital for guiding treatment decisions and determining the prognosis.
Okay, that makes sense. So we've figured out the why and the how of diagnosis. Let's talk treatment. The key principle seems to be you don't treat the yellow, you treat the cause of the yellow.
Absolutely fundamental. Icterus is a symptom. Treatment targets the underlying disease causing the hyperbilirubinemia.
So for prehepatic icterus, where the issue is excessive red cell breakdown,
The focus is managing whatever is causing the hemolysis. If it's autoimmune hemolytic anemia, that might mean corticosteroids or other immunosuppressants. If it's G6PD deficiency causing hemolysis triggered by certain drugs or foods, the treatment is avoiding those triggers.
what about supportive care?
Supportive care is important too. If the anemia is severe from all the hemolysis, blood transfusions might be needed. And because the body is rapidly turning over red blood cells, supplementing with folic acid is often recommended, as folate is needed to make new red cells.
Okay, now for hepatic icterus, where the liver itself is struggling, treatment depends entirely on the specific liver disease, right?
Entirely.
Yeah.
If it's chronic hepatitis C or B, the treatment is specific antiviral medications aimed at suppressing or clearing the virus.
And if it's alcohol-related?
For alcoholic liver disease, the absolute cornerstone is complete abstinence from alcohol. That's non-negotiable to allow the liver a chance to heal, if possible.
What about drug-induced liver injury?
First step is stopping the offending drug immediately. Usually, the liver will recover once the drug is removed, though supportive care might be needed.
And autoimmune hepatitis?
That typically requires immunosuppressants, often corticosteroids initially, sometimes other drugs long-term, to calm the immune attack on the liver.
What if the liver damage is already very advanced, like cirrhosis?
With cirrhosis, the damage is largely irreversible, so treatment focuses on managing the complications of cirrhosis, things like fluid buildup, ascites, bleeding from varices, hepatic encephalopathy. And in suitable candidates with end-stage liver disease, liver transplantation might be the only curative option.
Right, transplant. And is there anything to help with symptoms like the itching in hepatic cases?
Yes, that pruritus can be really debilitating. Medications like cholestyramine, which binds bile acids in the gut, can sometimes help relieve the itching associated with impaired bile flow, even in hepatic causes. Nutritional support is also key for chronic liver disease.
Okay, now for post-hepatic icterus, the obstructive kind, the main goal must be to relieve the blockage.
Exactly. Job number one is to unblock the drain. And as we discussed, ERCP is often the hero here.
For removing gallstones from the common duct.
Yes, ERCP with stone extraction is usually the first-line approach for choledochlythiasis, or ERCP with stent placement if the blockage is due to a stricture or a tumor that can't be removed immediately. The stent props the duct open.
What if ERCP isn't possible or it doesn't work? Or if it's a large tumor?
then surgical intervention might be needed. That could mean surgically removing gallstones or bypassing the blockage, or, if possible, surgically removing a tumor, like in pancreatic or bile duct cancer.
And treating the underlying cause of the obstruction is key too, right?
Absolutely. If the obstruction was caused by cancer, treatment will likely involve surgery, chemotherapy, and/or radiation therapy, depending on the type and stage of cancer. If it was caused by cholangitis, infection, antibiotics are crucial.
Makes sense. We should also touch on neonatal jaundice in newborns. It's common, but treated differently, isn't it?
Yes, it's a very special case. Most newborn jaundice is physiological, meaning it's due to the baby's immature liver not being quite up to speed with conjugating bilirubin yet, combined with faster red cell turnover.
So what's the usual treatment?
The most common treatment is phototherapy. The baby is placed under special blue-green lights.
How does light help?
The light energy actually changes the structure of the unconjugated bilirubin in the skin, converting it into isomers that are more water-soluble and can be excreted in urine and stool without needing conjugation by the liver. It's quite clever.
That is clever. Anything else?
Encouraging frequent feedings is also important. More feeding means more bowel movements, which helps eliminate bilirubin through the stool.
And for very severe cases in babies.
If bilirubin levels get dangerously high, posing a risk of brain damage, a condition called Icterus, more intensive treatments might be needed. This could include intravenous immunoglobulin, IVIG, especially if there's blood type incompatibility between mom and baby causing hemolysis. Or, in rare critical situations, an exchange transfusion, where the baby's blood is gradually removed and replaced with donor blood to rapidly lower bilirubin levels.
Okay, important distinctions for newborns. One last crucial point. You mentioned liver disease impacts how the body handles things. What about medications? Are there specific drugs to be careful with if someone has liver problems or jaundice?
Oh, absolutely critical point. The liver metabolizes many drugs. So if liver function is impaired, drug metabolism can be affected.
Meaning drugs might stick around longer or have stronger effects.
Exactly. Their duration or intensity can be increased. Plus, some drugs are inherently hepatotoxic, meaning they can directly damage the liver. These need to be avoided or used with extreme caution in patients with pre-existing liver disease.
Any examples from the sources?
Yes, they mention being cautious with certain anticonvulsants, anabolic steroids, some antipsychotics like phenothiazines, certain antibiotics like macrolides and tetracyclines. Tetracyclines, for instance, can also suppress protein synthesis in the liver, which is already a problem in severe liver disease.
So doses might need adjusting.
Definitely. Doses of many drugs, especially sedatives that are metabolized by the liver, often need to be reduced. It requires very careful prescribing and monitoring by the doctor. Really highlights how central the liver is to overall body function and medication handling.
It really does. So wrapping this up, we've taken this deep dive into Icterus. We started with that simple, striking yellowing and uncovered this incredibly complex story playing out inside the body.
It's a signal, a symptom, that sends doctors on a diagnostic trail from red blood cells breaking down through the intricate processing steps in the liver and down the bile ducts, following the bilirubin trail, essentially.
It really shows how a single sign can guide you to pinpoint exactly where a system has gone off track. It's a roadmap for diagnosis and ultimately for healing.
It is, and I think understanding these connections, how hemolysis links to liver function, links to bile flow, it's not just about memorizing pathways, it's about appreciating the sheer complexity and, honestly, the resilience of our bodies.
Yeah, absolutely.
Yeah.
So what does this all mean for you listening in? Maybe the next time you notice a symptom, any symptom, not just yellowing in, you won't just see it as an isolated thing.
Right. Maybe you'll see it as potentially a profound integrated message from your body, a clue.
Exactly. A clue inviting you or your doctor to unravel a deeper story. It really underscores how symptoms, even alarming ones, are just the body's way of communicating, its own sometimes eloquent language.